I'd like to welcome everyone to this Patient Safety Roundtable, and I'd like to first introduce my colleagues. Dr. Sundt.
Hello, I'm Sundt, the Chief of Cardiac Surgery at the Mass General Hospital. I've been involved in the patient safety effort since I was made chair of the patient safety workforce for the STS some years ago.
I'm Juan Sanchez. I'm Chairman of Surgery at St. Agnes in Baltimore, and I've been involved with the Society of Thoracic Surgery in patient safety efforts for quite some time.
And I'm Blair Marshall from Georgetown University. I took over for Dr. Sundt as chair of the workforce on patient safety. So I thought it would be nice to get together and sort of discuss how efforts in patient safety have changed the way you all have practiced. There are some current trends and new things that Juan's working on. Tor, how has your efforts in safety affected the way you care for your patients?
I think I'm a lot more aware of the importance of communication among team members to try and help everyone on the care team be involved in capturing errors and correcting errors. I think that empowering the whole team and engaging the whole team is the most important aspect, and on a daily basis I make efforts to encourage people to be engaged.
That involves a significant change in culture. How have you gone about doing that?
I think it is a significant change in culture, and it's a challenge for us, particularly in cardiothoracic surgery, I think, because we've been reared with an ethos of personal responsibility. My generation certainly was reared that you were responsible for everything that happened to the patient. The problem with that is it excludes the other caregivers to a great degree. The medical legal system reinforces that. There are a lot of forces that reinforce that independent practice mentality. But I think that when you become aware of the power and leverage that exists in the whole team, you realize how much benefit there is to your patients and to you by engaging them. And you have to change behaviors, and if you change behaviors over time, culture changes, I think.
The whole patient safety movement has really spurred us to reevaluate our whole system of care delivery, and we as cardiothoracic surgeons really oversee the most complicated set of care deliveries that you can imagine in healthcare. So the movement and some of the tools coming out of the science of human factors and ergonomics is helping us reevaluate that care so that we can provide that in a safe manner. Safety adverse events being a low-hanging fruit of the quality tree. So it's really has created an impetus for us to really evaluate how we communicate, how we hand off patients from one area of care to another.
You've been the chair of Mass General now for a very short time. Have you implemented any changes that might affect system-based issues that impact patient safety?
Sure. As I say, I've been focused on the active engagement of the entire team and encouraging people to speak up, other caregivers, non-physician caregivers, or other physicians other than the surgeon, primary surgeon responsible. And that requires a better understanding or appreciation of non-technical skills and your impact on those around you. I don't think we grew up, certainly in residency, worried about whether we hurt somebody's feelings or not. It turns out it matters if you hurt somebody's feelings or not, because if you hurt their feelings, they're not going to speak up when they see something that's going wrong. So to specifically answer your question, we've actually engaged in 2 rounds of 360-degree reviews of the surgical staff by anesthesiologists, other surgeons, the caregivers in the intensive care unit, on the step-down unit, in the operating room. And it's a little challenging when you first receive the feedback from the 360s. There are things that you thought you did well that you discover that you don't do well, all of us. And it can be a little tough to take at first, but you learn a lot. So I think everyone ought to engage in that. You have no idea how you come across to someone else until you ask them to give you the feedback. So that's a concrete example.
Mm-hmm. And is that done as a survey, or is that done person to person?
So it's the particular one we used is a commercially available one, and it's analyzed through a company on a web-based survey. There are folks who do 360-degree reviews just within their own institutions. So at Mayo, the 360 degrees could be processed internally. There was a mechanism for that. So your own institution, your university, your hospital may have a mechanism to collect those data. It's very important that they be anonymized and then fed back in an objective way. It's a hugely valuable experience.
This is important. It's an important concept in that, traditionally we've been trained in silos, professional and subspecialty silos, and the silos really have no relationship to each other. And now we are asked to train in a very complicated, increasingly complex technologically and in terms of communication, and we need to train together. And we're really not comfortable, the different specialties working together, the different professions, healthcare professions working together. And I think that's something that we're going to have to deal with and increasingly cross-train and train in multidisciplinary settings.
What would be your next task now where you are in order to improve safety, since you've already done the team training bit?
Well, I think that changing the culture takes years. So I would not say that we've changed the culture yet. We're working on specific behaviors. Behaviors are a reflection of culture, and culture is a product of behaviors. It's a little bit of a chicken and an egg. The behaviors you can objectively evaluate, you can train for, you can try and move the bar in that way. So I think that we'll continue to work on the teamwork behaviors in the operating room and on the step-down unit. We're working on empowering our allied health, our mid-level practitioners. That's important. You soon discover that even if you would have given 20 milligrams of Lasix and they gave 40 milligrams of Lasix, if you beat them up about 20 milligrams of Lasix, then they're not, you'll shut them down, they'll quit being involved, they'll disengage. So I think that that's one of the other aspects, is that we all need to develop some flexibility to help empower people and engage people. If they're not empowered, they won't be engaged, and if they're not engaged, they're not going to participate in capturing and correcting errors.
Do you use any means to capture or correct errors in your institution?
Well, we have certainly have our challenges. It's a different methodology to look at errors and sort of deconstruct them. There are tools from other industries that allow us to look and see what the root cause or the systemic cause of errors are, but it's a different kind of science that we are usually not been exposed to in medical school and in training. So we're trying to learn about these tools and try to adopt them, things like root cause analysis and other ways to look for potential errors that haven't happened yet. So we're still learning, but I think we have a long ways to go.
I find one of the greatest challenges where I work is the team concept and the traditional characteristics of some of the individuals that are from the older era mixed in with the current era don't necessarily adapt so well. It's a great challenge to me just to get them to see their behavior. Have you found any tools in particular that are useful in that fashion?
Well, we've talked about videotaping, and that has some interesting challenges, but I think that there probably would be value in that. And I agree with you. One of the challenges, generational challenges, is that we misinterpret the behaviors across different generations. So it's easy to misinterpret a behavior as someone not caring on either side, or someone being abusive for no reason. When we try to communicate across generations, we need some understanding of that. So I think that the more we understand each other in that regard, will help.
Juan, can you tell me a little bit about your work that you're doing with maintenance of certification?
Yes, the American Board of Thoracic Surgery is moving ahead with a patient safety module, which will be part of the maintenance of certification process. the Society of Thoracic Surgery has been tasked with creating the curriculum for that, and we are completing the curriculum currently, and will be going through the approval process both by the American Board of Thoracic Surgery and the American Board of Medical Specialties. So that curriculum should be available to certificate holders sometime later on in the year.
And will this be on an annual basis, or how often will you need to do the patient safety maintenance of certification?
The curriculum is designed to be done once during the entire MOC cycle, which is a 10-year cycle, and will provide 2.5 credits, Category 1 AMA credits.
So I guess if I had one suggestion, concrete suggestion for my fellow surgeons, it would be to incorporate in your practice right now efforts to encourage individuals to speak up. And there are two very concrete behaviors that I can imagine that I use that I've found helpful in encouraging people to speak up. And the first is, we don't realize how intimidating we are when we walk into a room. We have no idea of that. But the folks in the room are oftentimes afraid to speak up. And I make an effort, whether it's in a division meeting or making rounds in the intensive care unit or in the operating room, to first scan the room, identify the person who's least empowered, and have them speak first. And you'll be amazed what tumbles out. When you're making rounds on the floor, the least empowered individual actually is the patient. Not the least important, the least empowered individual is the patient. And it transforms rounds into a truly patient-centered experience. It's not the way we were taught to make rounds. It's not the way I made rounds when I was a resident. But it creates patient-centered rounds, and it encourages people to speak up. And I've oftentimes said that when the patient care tech advises you that Mrs. Smith hasn't gotten her beta blockers, then you've won. That's what you want. You want the whole team engaged, speaking up, capturing errors and correcting them. And the second thing is that what I do in the operating room, the best I can, is that if someone corrects me, if someone says, I think you backwalled that stitch, or I don't think the cross clamp's all the way across the aorta, or whatever, I check it. I always, whether they're right or wrong, I always thank them for paying attention. So, nope, the anastomosis is fine, but thank you for paying attention. And if you confirm each time that you appreciate them speaking up, then they'll speak up when you need them to. Because when you really need them to speak up is when you're wrong and you don't know it.
I think that's where the safety comes in, preventing us from making errors, recovery from error.
That's right.
So just to summarize our thoughts here, for those of you who aren't aware, patient safety is here to stay. And if you look at where the funding, research funding today is, the basic science funding is more challenging than ever, but the only place where funding is growing is in patient safety. And those concepts that Dr. Sundt talked about, changing your culture at your institution, getting those below you, instead of our traditional top-down approach, getting those under you to speak up when they see something wrong is the way to move forward and help us recover from errors that we might be making.